Well, why don't we get started? Welcome, everyone. I'm Dennis Nash. For those of you that don't know me, I'm faculty in epidemiology here at the CUNY School of Public Health, and I'm the executive director of the CUNY Institute for Implementation Science and Population Health. It's my honor and privilege to introduce my colleague and friend today, Dr. Milton Wainberg, who will be our grand round speaker. Dr. Weinberg is a psychiatrist and a professor of psychiatry at Columbia University Medical Center, and not far from us in Washington Heights. And he is an implementation science researcher whose work focuses on bringing research to practice within public mental health systems of care in low resource settings and in the US, as well as low and middle income countries. And he also focuses on training the next generation of mental health clinicians and researchers, including with a focus on implementation science. Dr. Weinberg did his medical training at the Central University of Venezuela in Caracas, and he did his residency and fellowship in psychiatry at the Mount Sinai Medical Center here in New York. He was born in Caracas, but I learned today that he holds citizenship in the US, Venezuela, Brazil, and Spain. Much of Dr. Weinberg's research has been funded by multiple different NIH institutes, but broadly funded by the NIH, including NIMH, NIDA, and the National Institute on Alcohol. He also has recently been funded by the Fogarty International Center, and he leads a D43 within the IDEA collaboration, collaborating with the Asia Pacific region. And this D43 that Milton leads is focused on mental health and HIV implementation science. And it's been a new avenue of collaboration for us, which has been great. He is an affiliated investigator with the CUNY Institute for Implementation Science and Population Health. We're lucky to have him in that role, and he's been a great collaborator and supporter of our work and the work of the school. Most recently, he joined us on the renewal of our Central African region of IDEA. This is the observational HIV cohorts in Central Africa that we've been following, and that was funded over the summer. And so we're entering our years 16 through 20 of that work. And he will help us build out mental health and implementation science in the IDEA network. And today, Milton will be speaking to us about some of his work and implementation science perspectives in a talk called Global is Local, Ending Mental Health Disparities. Milton, welcome to the CUNY SPH, and I thank you very much for joining us today and taking time to speak with us.
Thank you so much, Dennis. It's such a pleasure, and I love working with you, so I'm hoping that all our collaborations grow and that we can bring people together from CUNY and from Colombia and other countries in what we're doing. So thank you for having me. Global is Local, Ending Health Disparities. So let me, number one, it takes more than a village. As you can see, we have the IDEA people here too. So this is many collaborations that have been part of all of these. It includes postdoctoral fellows, people who have been working with me in a supplement in New York, consultants that are wonderful to play with. We have University of Pennsylvania, in South Africa, people in the Foundation for Professional Development, Vanderbilt, Sao Paulo, NYU, Connecticut. It would seem that I don't know how to do anything and that I need all these people to help me. But it's a wonderful collaboration that we have. Mozambique has been an extraordinary place to work. We also have fellows from Sub-Saharan Africa. As Dennis mentioned, Treat Asia, we have the D43 and the IDEA. And I'm going to be talking about work that was funded by these. And hopefully some of you will be joining the work. So we cannot forget COVID, not yet, and maybe I don't know when. We're not going to talk about that, don't worry. One of the important things after all of these things that we know, the first wave of median mortality, then the second wave of impact of resource restriction, because urgent issues were complicated, the tail with ICU, then the impact on chronic conditions, but then mental health has been growing and growing and growing and growing, and both for patients and providers. And I just want to remind everybody that we in the field of helping are also people who feel and have problems and carry genes and have disorders. And it's not a weakness, so we need to be able to take care of ourselves. So today's talk, I'm going to talk a little bit about the burden of mental and substance use disorders, the global and local treatment gap, the research to practice gap that Dennis was referring to. Can science help? I'm going to talk a little bit about scaling up comprehensive mental health using 100% task shifting sharing from local to global. Task shifting and sharing means that somebody without the specialty training is charged with doing the mental health work. It could be from a layperson to a primary care provider. The electronic mental wellness digital screening, triage, and treatment tool that we have developed, and a little bit of the work that's taking place with COVID. So burden and early mortality. This is data that we have since 1990. And in 2019, as you can see, you have for mental disorders, years lost to disability. So this is about disability in the most productive people, #1 in every continent. And with regards to DALY, which is adding to that the years lost to life, it's between #1 and #2 in every continent. So it is pretty clear that mental and substance use disorders are the leading cause of disability worldwide across sexes and entire lifespan. And on the other hand, we also know that people with with MSDs experience poor physical health and have an average life expectancy that is 15 to 25 years shorter than the general population. And we've known this for a little while. So despite the evidence of multiple effective short-term psychotherapy treatments and medications, henceforth, I'm going to call them evidence-based interventions, that reduce the impact of mental and substance use disorders, no reduction in the global prevalence or burden has been detected since 1990, which was the first time that they did the burden of disease study. The scaling up of evidence-based intervention has not been a priority globally. So this is how busy I should be with a number of providers in mental health. I should be taking care of 2 million people. So I'm going to say goodbye and start treating people nowadays. So the reality is that there's not enough of us. And that is even worse in low and middle income countries. So we know that the LDL number should be about 45 for 100,000. The low income countries have 0.1 psychiatrists and 0.3 psychiatric nurses. The US has a number of 13 over 100, Switzerland 39. And in high income countries, the rate of psychiatrists is 120 times greater than low and middle income countries, and 75 times greater for psychiatric nurses. So the reality of when 90% of the population exists, which is in low and middle income country, is that they have the least amount of providers. And that, of course, leads to a mental health treatment gap that is vast, especially in low and middle income countries. So you can see in high income countries, between 35 and 50, people don't have access to care, whereas in low and middle income countries, between 76 and 85. So let's talk about the US. Half of people in the US will be diagnosed with one of these disorders in their lifetime, yet only half will receive proper treatment. And many of you are very well aware of the HIV cascade. And so Brian Pence, a colleague at UNC, and many of you may know him, decided to try to create the similar one with depression care in the US. And these are the numbers, prevalent cases, recognized clinically, any treatment, adequate treatment, achieve remission. So no 90, 90, 90. We're not even close to what we should be. And the situation is even worse for adolescents. 2 out of 3 youths with depression are not identified. And young adolescents, children and adolescents tend to see the doctor more frequently than others because they get vaccinations. So we're talking, this is the US again. So we're talking about even if they are clinically in a situation that they should be seen, nobody looks at them. So the global, I call it global to local, mental and substance use disorder treatment gap is very clear in the US. So it's not only in low and middle income countries. So what happens in the US? Of course, as usual, for some reason, some groups always get the short end of the stick. The mental and substance use disorder treatment gap is even wider in African Americans, Latinos, impoverished rural populations who, compared to urban non-Hispanic whites, have less access to quality care and higher rates of early treatment discontinuation, which, I'm not going to go too much into this, but we know some of the reasons why these populations don't feel safe within our environment. And what happens, as we know also, is that the social determinants of health such as poverty, unemployment, stigma, lower access to healthcare resources, and digital infrastructure. So, in the COVID era that we're doing much more many things digitally, therefore, there is more burden, more less access to care for them, discrimination and structural racism. And COVID, obviously, and unfortunately, has worsened these disparities. So this is the situation that we have with the burden and mortality in the US. So the current mental and substance use disorder model of care, we have in primary care, we have managed to do collaborative care, where primary care providers tend to treat depression and anxiety. And I'm talking in public health systems. Then the mental health specialists are the line for treatment, and acute care would be emergency rooms or inpatient care. And these are the current health system, primary and tertiary. There are mental health specialties in the communities, but they function the same as, so the community mental health setting, they function as a clinic in a hospital, but they're in the community, which is a little better, but still it's a very archaic and very unable to access care model. So some of the solutions that have been proposed, and these have been there for many years, and HIV was a perfect example of how to do it. Some of us who have been working HIV for many, many years learned that antiretrovirals needed to be spread through Sub-Saharan Africa. There were not enough physicians to do it. So nurses were trained to do the work that physicians do it here in the US. And the same thing with mental health to some degree. It's reassignment of specific mental health assessment and treatments with abbreviated training and ongoing supervision to people who are not the specialists. Unfortunately, the way that this has been done, and I'm going to say it very sadly, in the world of HIV, it has not been about using evidence-based treatments. The funding that has been there for HIV and mental health only has started recently. Prior to that, it was more like there would be somebody doing psychosocial interventions, as they call it, that probably had a combination of elements from multiple interventions or some counseling, and none of them had evidence. And unfortunately, we know that they were not successful at achieving things. And only recently, as I mentioned, NIMH and PEPFAR and others decided, and USAID decided that we need to include mental health. Another one is integrating care. We used to be referral and consultations, more collocated and then more integrated, where the psychiatrists, for example, and the psychologists and the social worker are part of the medical team. And again, with this, HIV was the leader in these areas. Pain management in the US and HIV were the ones who did this the most, and palliative care. And the other model that is being used also, which is a much more efficient method, which is the step care model, which responds to the reality that we don't have enough providers. So individuals' needs are matched to the appropriate level of care. Not everybody needs to see a psychiatrist, and more intensive interventions only used if required. And this is combined with this, of course, because you train others to do the work that mental health specialists are doing. So the step care model that we should be thinking about, again, I explained that more specialized, it's the complex cases, low intensity in the bottom. So self-help and patients exhibiting subthreshold disorders, we need to think of prevention and methods that we can use, and digital work can be done for that. Then in a step 2, evidence-based interventions by lay personnel, peers, community health workers, nurses, and social workers. A step 3 could be the collaborative care, where depression and anxiety are treated in primary care, and only the complex cases are done by mental health specialists. And these should be involved in the training and supervision of all of these. So that's the assumption. And then it's divided into more tertiary, primary, and there's much more community care that can be done. So there have been mixed results about primary care providers doing the collaborative care because they're overwhelmed by the amount of patients that they have to see, and they have 15 minutes to see a patient, and then they feel, okay, now I have to take care of depression and anxiety. So it's a complicated situation for primary care providers. Another element that we have in the US is that the shortage means that you're in a wait list. I can tell you that the person who has been always helping us with our children, her son witnessed the murder of his father in El Salvador. came to the US, was having a very hard time. And in the school, they said that he needed to get seen by a psychiatrist or a child psychiatrist. And then first available appointment was 9 months after they consulted where they could go. Obviously, I'm at Columbia and I helped the kid get into proper care, but not everybody has access to a psychiatrist at Columbia. 9 months basically would have meant that he would have lost another year in his education. So the shortages create these. One of the problems is once a patient, always a patient. It's almost like there's a dialysis machine and it's mine no matter what. Maybe I share it with the people that my therapist can see, but the system is not trained to figure out how to do more short-term work. Even if enough providers may be available, reimbursement issues maintain mental health provider shortages also. Our training modes do not focus on a public mental health lens. And this is something that I'm sure you in the School of Public Health are very aware of. And it's not just in mental health, by the way, it's also in other disorders. We're very well trained to do a one-on-one treatment, but medical school, nursing school, psychology school, psychiatry school, whatever we're talking about, the idea that you're paying attention to a public health lens is never there. And we don't use short-term treatments. And the system of care is not organized to provide services using short-term modalities that we know are effective. And not every patient, again, needs to be seen by a mental health specialist. So maybe these people that are waiting can be seen by somebody else while they wait for a mental health specialist. And maybe along the way, they may get the treatment that they need. And they free space for people to be seen in the mental health system. So the waiting would have been much shorter. The other element that is quite important is that once people are in mental health care, the dropout is dramatically horrible. It can be either in the mental health sector or in the general medical and human services sector. So 60% of people drop between 3 to 6 sessions, which means we have a very short period of time to treat 60% of the people who will leave. So shouldn't we be thinking about using a short-term model? And then for those that need more, we figure out what to do. Because what ends up happening is that we only treat the people who can stay longer, who may not have childcare, work, etc., and it becomes very complicated or are so ill that they're required to be seen on a more regular basis. So reasons for the vast mental health treatment gap, except for medications and procedures, few evidence-based therapies make it to the real world. Low and middle income countries, most medications are not available. So for example, in many countries, you only get primary care providers that are not allowed to provide psychiatric medications. In the US, insurance coverage is a limited availability, so you may not have access to certain medications because of the insurance that you have, if you have insurance, of course. And trained to address health and mental health is one patient at a time, no public health lens, as I've been saying. There are not enough providers. Mental health disorders are hard to screen for. Training in evidence-based therapy takes time and supervision and doesn't happen in many places. There are multiple stakeholders and funding that must come together to make this happen. Stigma and misconceptions that, it's a weakness, so it's very hard to get care in some places. I remember early in the HIV epidemic, I had a nurse who was working in the hospital where I was seeing patients, and he didn't want to be seen in the HIV clinic, nor by me, that anybody would know that he was seeing us. So we literally closed the clinic and would see this person when the clinic was closed because of the concern of the stigma. The science of bringing research to practice is young and not used so much in the systems of care, and research focuses on one disorder at a time. And that's a very important element, and I'll explain more a little bit in a second. So can science do something about this? And I know that I can get in trouble when I say this, but I say it because I believe that perfection is the enemy of progress. There's an element of rigor that we do in science that works against us. I'm sure that all of you have your children in schools that have done randomized clinical trials for the interventions that they do to teach math, English, poetry, music. And in colleges, I am sure that we do randomized clinical trials before we have specific trainings that we do for buildings that we live in, for many other things. In other words, somehow, and I'm not going against the scientific model, if I create an intervention and I do it in the 86th Street in the Upper West Side, If I want to implement it in 77th Street, somebody may say you need to adapt it. So there's an element where we need to think a little bit more clearly what we do. And this is one of the reasons, this is the time that takes 17 years for 14% of evidence to be put into practice. And this is not mental health, this is all of them. Mental health behavioral interventions are worse because remember, one of them could be developing a medication and being used, whereas mental health interventions are different sessions. You need expertise in training, you need expertise in doing the RCT, so it's a much more complicated business. So what is the research continuum? Of course, I'm going to do epidemiology as one important one because I am presenting to the School of Public Health. So epidemiology informs a lot, right? And then we develop some things to try to figure out the disorders that we want to treat. And we have a whole system from basics to safety to efficacy, effectiveness, and then at the end, implementation. And this is where I'm really concerned in psychiatry, which is we do one disorder at a time. So we do depression through all of these. And then when we need to implement it, we're doing depression when people have comorbidities. And it's a complicated situation. And that's why I write, the very basic New York answer, or they. So why am I saying that it's complicated? Because, this is a study that I'm going to show you some results that we did to validate measures in Mozambique. And common mental disorders are depression, anxiety, and PTSD. So even this number may have comorbidities. Severe disorders are mania and psychosis. So these could be comorbidities. And then two or more categories were 24%. And remember, this includes 3 disorders at a time, which means that the world is not one disorder at a time, but that's what we do. Traditionally in research, we really look for patient outcomes. We want clinical effectiveness. And the question that we need to ask ourselves, is that enough? And the reality is that we have a public health lens. We need to think how services are provided. Is it safe? Is it equity? Let's talk about, are African Americans, Latino, and rural people getting the same access? Are women and men getting the same access? Age? So is there equity? Is there efficient? You are seen today, you get screened as positive. Does it take a week to be seen? Does it take 3 months to be seen? And the timeliness according to the severity. Somebody that is very acute today should not be waiting. I remember I was the director of an HIV mental health, of the mental health part of an HIV clinic at St. Luke's Roosevelt with 5,000 patients. When I arrived, if you wanted to be seen by the psychiatrist, you had to wait anywhere between 2 to 6 weeks. And of course, sometimes people don't show it. So they wait, but they don't come because they forget, etc. So we did an efficiency and timeliness method that we would ask the primary care provider, the HIV provider, to basically determine severity. And we told them, if you put everybody as severe, everybody's going to take 4 to 6 weeks to be seen. But if you tell me that somebody needs to be seen today, tomorrow, or in a week, the timeliness and efficiency was amazing, and people only needed to wait 1 week to be seen. So those are services. But then is the implementation outcomes. And I'm talking about how do you bring evidence to the field. You first need to be acceptable, feasible to be done. There has to be adoption, which is the early element, penetration, which is a little bit later on, and the complete uptake, fidelity to the intervention, because you want to make sure that they don't do their version of it, just like you wouldn't do that you would give half of the dose of antiretrovirals to people, addressing cost and sustainability. And as I tell all my students, the robust 3 words that I want them to always remember: sustainability, sustainability, sustainability. Everything that we do, we need to think, is it going to be staying or not? And how do we make sure that it's sustainable? Because otherwise it's a beautiful paper and a beautiful grant, but if it doesn't lead to sustainability. So can we do something about it even early on? So we know that in efficacy trial, we do an intervention, we do a control, randomization, good or bad. And most of the time, let's say that we find fantastic, but sometimes we don't find good results, or we find mixed results. And we use the quantitative data to try to figure out what we can figure out. But the reality is that we don't know everything about it, how it was done. So is there a mixed methods that we can be incorporated? And can we test who does the intervention versus not? That would be more implementation, right? And then effectiveness, we have the same story. You have an intervention, you have a control, but there are questions that we cannot answer because we don't ask them. So we rely on very little data to try to come up with a lot of information. And in order to really understand that, you may want to figure out how do you do an implementation strategy. For example, the intervention can be done either by a psychologist or a social worker or a layperson versus a more controlled strategy, which would be the person that usually does. And you can stratify, you can do many models to try to understand also how to implement it. And that's where the hybrid implementation, effectiveness implementation studies that are being conducted are happening. So why do we need to think about this? There's very clear theories of diffusion of innovation, which are the factors associated with people adopting things. It has individual level issues, context, and type of innovation, because it could be too complicated, or like a treatment, you would need to come every day for the next 20 years to be treated. That would be too complicated. So you have the innovators, those are the ones who immediately buy the first, the iPhone when it comes out, or this when it comes out, or seeks in media to have a new treatment, early adopters, early majority, late adopters, and laggards. So there is and I'm sure that all of you have different levels on that. And imagine that you're either a provider or a patient. Among you, if there's a new drug that becomes available, where do you fit in this? Would you want to be among the first ones to use it, or or to prescribe it if you're a provider? And some people say, "Oh, I want to be the first one." So it's like, I'm going to wait, the 3 people that I know are innovators. I'm going to see how they do it, and then maybe I'll do it. And then there are the others. Well, I'm going to wait for a lot of people, and then they're the late adopters or non-adopters, and that also happens a lot in psychotherapy, because if I'm trained to do one therapy, the idea that I'm going to have to be trained to do something else, it's complicated. And I remember very clearly, we used to train with a group of us, would go to HIV settings to do motivational interviewing trainings for the whole clinic. And the most complicated people to train were the psychologists and social workers, because they felt that they knew how to do it, when of course they didn't know, because they didn't understand what motivational interviewing was, but they thought it's motivating people. So the idea would be how you increase and you decrease these. So why is this so important? I'm introducing an evidence-based intervention. That intervention is between a patient and a provider. It's within an organization and a structure. And all of these can influence that. Besides, you also have family, friends, and neighbors. No, you should not see a therapist. Oh, by all means, you cannot do CBT, or you cannot do that. Why are you doing these things? So there's always an element of religion, culture, social position, income, gender, etc., that can impact. And also how the governance, policies, insurance, reimbursement, and societal norms are behind this. So this little evidence-based intervention that could be fantastic is very dependent on many of these things for it to happen. So this is where implementation science comes in. It's how you get implementation. It's the active adoption. Now, science relies on journals, articles, and conferences. And occasionally somebody gets interviewed in a paper, in a journal. I'm sorry, in a newspaper. So what we do in implementation science is try to figure out active strategies to introduce evidence-based mental health interventions in diverse real-world settings. It's not just mental health, but I'm talking about these. So the idea is to try to reduce this, right? So we don't have 17 years. Let me talk a little bit about my team and collaborators, because we're really proud of what we've been doing. So in 2012, there was no implementation science in psychiatry, and I decided that I needed to create an implementation science core within the setting. So we first developed a T32, where these are the people that have been or are part of it, wonderful people doing amazing work in multiple places, like including the US and Puerto Rico. Some people have gotten K awards, which is an independent award that people get after a postdoctoral T32, and people have also gotten tenure track positions. So we have been very successful in multiple places. And I also, obviously, my mother used to say, you knock at the door, see if they open. I've knocked at Denny's door multiple times, and he has opened the door for me. So that's where IDEA is here. So we develop partnerships through different capacity building grants, and you have some of them, and also through research projects that we had. So Fogarty training in Mozambique. Then we had a large study that I'm going to talk about. Then NAAA reduction of alcohol in Mozambique. More recently, with ANET in Asia Pacific, AMFAR, we're doing the Chimera, which is also capacity building, and now we're starting the IDEA in 3 different one of them. I'm going to talk a little bit about Mozambique, where we have had a very powerful collaboration. Depending on the year, is the fourth or the sixth poorest country in the world. It's 70% rural, 90% within an hour of primary care clinics. So you have access. They have rural clinics in multiple places. The HIV rate, depending on the province, is 9 to 19%, much higher than the US. Of course, the public health system is free for all. Their community level primary health clinics, there's no mental health care. And even in these clinics, they don't have doctors, they have what is called medicine technicians that they were trained to do the job of doctors. Urban district and provision level clinics and hospitals do exist. The mental health system is also free, but there's only in urban mental health specialty clinics. There are about 600 mental health specialists for 29 million people that include the task-shifting psychiatric technicians that they provide care in cities. So 70% of the rural areas lack mental health care. There are about 150 psychologists, and there are a total of 18 psychiatrists at hospitals. There were no validated measures when we arrived there, and there's a huge treatment gap because of that. So how I started my work in Mozambique, Sten Verman, who's a friend and has at the School of Public Health in Yale, he realized the true story is that we wrote a grant to be done in Brazil. We got a phenomenal score, and between review and counsel, for those of you, review is done by researchers who meet to review and give you a number. And then a few months go by and there's the council where the NIMH meets to decide who gets funded. Brazil became a middle high income country, so we were not eligible for the. So I was talking to him and he said, okay, you have the Brazil team, let's do Mozambique. So I went to Mozambique and we started a phenomenal collaboration. And the way that we did it was, I went to do a training on HIV and mental health, which of course they know more about it. They have more HIV than I've ever seen in my life. But it was an opportunity. There were 18 people that I was training. And among them was the director of mental health of the country, of the Ministry of Health, which when she introduced herself, she said it very low. And I asked, is she part of the Ministry of Health? Yeah, she's the director. So I stopped and I said, can you have coffee afterwards? Maybe a drink, and I don't know, maybe we can work for 20 years and our grandchildren can work together. She laughed, but that's exactly what we're doing. And she became a fellow in our D43 Fogarty grant in Mozambique. So all the other fellows were like, oh, I'm going to do perinatal depression. Oh, I'm going to do, HIV depression. She is in charge of the ministry. So, she couldn't do a little project. And her concern was that the needs were growing. They had trained psychiatric technicians a few at a time. Now they didn't know even how to supervise them. Because remember, there are very few psychiatrists and psychologists in the system to supervise the work. And they used to go to provinces, et cetera, but she felt that she couldn't ensure quality of care. So in talking to her, and these were the questions that we're talking about that are very important when you want to work with your communities, with the people that you want to work with. There has to be bilateral learning and communication. So we came up with a method that, okay, we need to figure out how we do self-help. That's more complicated in Mozambique, and we haven't yet figured out how to do it, but it's about working with the community, and that's our next step. Then evidence-based interventions by lay personnel, so the community health workers, medication management by the primary care provider. Remember, they have not been prescribing medication. So 70% of the country doesn't have access to psychiatric medication, and only the complex and severe cases by psychiatric technicians. They supervise all the work here, and the mental health specialists also do training and supervision. So this is the system that we created. We wrote this crazy study that we're doing comprehensive mental health care. You remember that I was saying at the beginning that most studies do one disorder at a time. There are a couple that do two and maybe three that do three. We're doing all disorders. And the idea is to figure out what is the best implementation strategy. So who can do this? So we have the usual care, district level, and the pathway to would be clinic level, that only nurses and primary care providers in the clinic, which are medicine technicians, provide screen and do also medication and evidence-based interventions. And then also the idea of splitting between community and clinic, where the community health workers do the screening and evidence-based treatment, and only clinic providers only do medication. And we're going to be working, this is a 2-to-1 ratio that we're going to be working in 3 districts, different clinics, and these are the number of families that we're going to be reaching. It's a population about 7 to 8 million that we may be reaching, but we're not going to reach it. Otherwise, I'm going to be very anxious, and then he's going to have to help me with the amount of data, and I'm sure he will. So remember that I also mentioned to you that we don't have validated measures in Mozambique. So we first had to validate all the measures. So this was not just to validate the PHQ-9, for depression, or the GAD for anxiety. We needed to validate all of it. And after validating, I had this idea that I should have asked the community health worker coordinator for the country in the ministry how to engage the community health workers. So we sat down with him. Again, you need to talk with policymakers or the people that you're working with in the community, participatory research. And, community health workers, they get paid a penny or a quarter in comparison to others. And yet they do, in Mozambique, they do malaria, they do HIV, they do perinatal, kids with diarrhea, vaccinations. They do so much. And everybody wants them to do more because they're in the community. They want them to take the blood pressure, et cetera, et cetera. So here I'm talking to him and says, we're going to treat all disorders. How many questions can they ask? And he said, well, I don't know, 3 to 6. It's like Orve, another Orve. How do we do all disorders with 3 to 6? So we needed to create an all-purpose mental health screener that needs to identify a wide range of psychiatric disorders, needs to be very brief, again, 3 to 6, needs to be reliable and valid with direct interview, and a proxy informant. Why? Because the way that things work in Mozambique, the community worker doesn't speak with every member of the family. They go to a family, they find, the mother, the grandmother who's the informant, and they know them because they live in the community. And it's about, okay, how's everybody doing? Anybody pregnant since last time? Who's having diarrhea, et cetera, et cetera. So it had to be also by proxy. It needs to be able to screen as well as triage, because we don't just want to know that people have a disorder. We need to be sensitive to identify a problem and specific to be able to triage into care. So we knew that we were going to be using these treatments. Interpersonal counseling comes from interpersonal therapy. Both have been used all over the world. Medication, we know that they work. Safety planning intervention for suicide risk, and motivational interviewing within the SBIRD for a substance use disorder. So we knew that we would do all of that. So then we needed to screen and triage for that. So the question is, how do we do common disorders to treat this, to be treated by these, severe disorders, suicide risk, and alcohol? That was the plan. So these are the screeners that we decided. We also did functioning because a disorder in mental health, a disorder is a disorder not only when you have the symptoms, but you have to have functional problems with that. So these were the scales. We had 99 items that we looked into. And once we did the validation of all of them against the gold standard, the Mini Plus, then we needed to figure out, okay, how do we reduce from 99 to 3 to 6? So Melanie Wall, who's at our department in psychiatry, who's brilliant, I went to her and I said, we need to do 3 to 5. I said 5, so she would get a little bit more scared. And she said, you're absolutely crazy, Milton. We cannot do these. But then she came back a week later, I found a model that we can use, which has not been used necessarily for this, but has been used for other measures. And then you can vary the shrinkage. So the way this happens is that LASSO reduces all of, according to the disorders, is in comparison with the mini diagnosis. The mini, is a diagnostic interview for psychiatric disorders that have been validated all over the world. So LASSO tells you, okay, these 22 items can develop any disorder. And 22 actually was the first number. So then we pushed the shrinkage to see how many items we can reduce to classify disorders, any disorder in category. But we also decided that we're not going to let LASSO make all the decisions. So for every iteration of these, we consulted with experts into specific disorders to make sure that they felt that what we were doing was kosher, that it was in good shape. So we had a development sample. This is where we validated all the measures. Once we created the tool, we did a validation, and this is the amount of people that we saw. And I have to tell you, we saw these 966 in 5 weeks, and these ones in 4 weeks. So it was very easy to recruit. And this is what we found. And remember that I showed you, so let me just tell you, remember, this is by disorder. So the variability and the comorbidity is very high, as I already discussed with you before. So we were very lucky. We were able to identify a hand sensitivity of 94 for any disorder, and then sensitivity and specificity for the different categories that I've been mentioning to you did very well. And this one, which is for severe disorders, we obviously, after we say that you have a severe disorder, then we become much more clear about each diagnosis that is severe to make sure that we treat it properly. And we were also very lucky with the proxy, a 73% sensitivity. So, and it has to be a family, and non-family was not a good idea. So I also want to show you, Mozambique is an HIV 9 to 19. So we also wanted to see how HIV would behave. And we were very good in any disorder with sensitivity. And same thing with the specificity for disorders. So you have the HIV negative versus the HIV positive. And these are the numbers that we had in the study. So we can use also for people with HIV, which was very important. I want to show you how, why we're trying to push this measure, because we believe it's a very good one. Number one, the PHQ-4, which is being used now to identify two disorders, depression and anxiety, has 4 items, the 2 first items of the PHQ-9 and the G87. And ours has 1 item from the PHQ-9 and 2 from the G87. So these are the questions that the PHQ-4 asks, and these are the questions that the mental wellness tool asks. So there's some that are similar, and there's a difference. And this is how we categorize. We do a yes, no, to be able to determine categorizations. And so what is the behavior with regards to the mini depression and mini anxiety, the sensitivity of the PHQ-4? So you can see they're very similar sensitivity specificities, which we're not that interested because it's more about sensitivity. And again, for anxiety and depression, they both behave very well. So it's good. You can use either one of them for anxiety and depression. And for HIV positive, exactly the same. You can have the ability to do with the PHQ-4 in the PHQ for depression or anxiety. And even though I would love to say that this is better than this one, they're very similar in significance. So the sensitivity is very similar. So what are the advantages of ours? It's the comparable in sensitivity and specificity for anxiety and depression in a full sample and subsample of individuals with HIV. However, ours has some advantages. Number one is comprehensive, in what it means that the 3 items tell me not only depression and anxiety, but they're also telling me that there could be another disorder. And if I follow up by doing more, 9 more items, I can categorize, and I'll show you more in a minute. However, which with the PHQ-4 you don't do, there's no method of categorizing. And for example, remember that I mentioned to you the comorbidities. People can have depression and anxiety and still have psychosis. And there are many times that people are identified for one or the other, and other disorders are not identified. We also have a proxy that we know can work to identify, and the brevity. When you have to see 250 to 500 families to ask 3 items versus 4 items, it's a very different matter. So how would it work? The community health worker goes into a household, always finds, the woman that they tend to talk to. It tends to be a woman. And she's the one who gives information about the status of the family. So this is how it works all the time. With the proxy, we can ask 3 questions about each one of them, and 73% sensitivity for any disorder. So then the community health worker has to either talk on the phone or meet that person, ask the 3 questions, 94 sensitivity, 9 more questions. We know if it's acute, no disorder, or we have any of the other categories with these specificities, and then we can immediately triage to care. All of these we have put in tablets. It's interactive, it's engaging, and it's connected in a way that I know if you are using the tablet and you're not, for example, in the frame of safety planning or in motivation interviewing, there are multiple frames in your tablet. If everybody has a mean time in a frame that it's about 3 minutes and you have 20, that means that you're not using intervention. So we have metadata to figure out when somebody is using the tool properly or not. So we have access to go to them in a nice way and said, it seems to be, Milton, that you're having issues with this particular frame. Shall we meet and talk a little bit about it? And of course, we also have clinical supervision. So we call this the electronic mental wellness tool. Innovation, sustainable. We use existing resources. We didn't hire anybody new. We used the community health workers and everybody to train that were part of the system, and the technology will remain. It's the first study doing comprehensive mental health care. Previous studies address 1 or 2 disorders. We have the tool that is very brief that explain, and all interventions are evidence-based, short-term treatments within the system of care in primary care. And remember that I said to you how long people stay, and we have chronic disorders, but we can do sequential treatment for different comorbidities, combined treatments as an alternative, and then let you go and you can come back because we stay in contact with you. It's 100% of shifting. As I mentioned, both providers are community health workers and medicine technicians and nurses. I should have written that here. And the supervisor are actually psychiatric technicians. So the way it works, of course, although maybe they don't have a bell, they ring the bell to gather all the information, and immediately everybody has access to it. So this is the tablet. We have the tool, the interventions. I'm going to go very quickly so you see how the screens look. This is for substance abuse that you can categorize, and we use things that are there. And when you click on here, you get information. When you click on here, it tells you what you need to say of how it affects the brain. So there's some psychoeducation, and you can measure where things are. Then interpersonal counseling is first understanding that you're not weak. You have a disease. There's a sick role. Interpersonal means we want to understand who are the people in your life, and we determine who are they, and if they are positive or negative in your life, then they get identified. And then the 4 areas that tend to be used for the treatment: grief, disputes, life transitions, and loneliness. And within the disputes, there is a intimate partner violence, a specific model. And then safety planning intervention for suicide. It always starts with a severity scale for suicide. If there's low level and you don't need an intervention, we still ask you, just to make sure. Because one of the things that we do in asking about suicide, providers tell patients, you're not suicidal, correct? Instead of asking the questions, because people are very afraid. So these ask the questions, and then determines the need, or if there's an emergency response, and then in each side there is a rescue protocol. And then there's psychoeducation. Suicide, it doesn't stay forever. The ideas come and go. Their thoughts and physical, there are things associated with it. We create a safety plan. And for example, part of it is, it's warning signs, internal coping strategies. When you have a skill, we try to use a skill that you already have. The people, the places, families, and environment safe. And in Mozambique, it was very important to work with that. And so these are the evidence-based interventions that we're using, and there are many of them. They have been contextually and culturally adapted, which is what we did, tested, and some have been replicated. However, the data on how to deliver them is extremely limited, both in high-income countries and low-middle-income countries. So I think that I'm going to end by showing you the challenges of bringing evidence-based intervention. So even though I'm in an audience where there are many epidemiologists, I love epidemiologists and I work with many of them. That sounds so terrible the way I just said it. One of the things, it's important to make decisions. However, one of the things that when we started the D43 in Mozambique, they were not, the epidemiological data was not very good. And then everybody said, you first have to do epidemiology. It's like, well, you may be right that the rates of depression or anxiety or PTSD may not be the same, but we know we have them. So I think that without doing an epidemiological study, and Dennis, don't kill me that I'm saying this, we can start doing implementation science and bring research to practice. Validation of tools, again, very good in our countries, terrible in low-middle income countries. Trained mental health providers, we're doing so here. We're not doing that great, and even worse in low-middle income countries. Psychotropics prescribed within the system were very good here, terrible in low-middle income countries. Evidence-based therapy tested for efficacy, definitely in high-income countries. It's below average in low-middle income countries. Effectiveness, we have about 3, so we are sort of like above average in the US, low and middle income countries. Implementation were terrible in the US, and even more terrible in low and middle income countries, and talk about therapies for more than one disorder. As I was mentioning, that doesn't exist. Evidence-based treatments utilized within the system of care, not very good in our countries, terrible in low and middle income countries. So I'm showing you the difficulties, reporting systems, digital infrastructure, mental health policies. Look at that. We have not so good policies here and terrible in funding. Less than 5% of our funding goes to mental health, less than 1% goes in low and middle income countries. So obviously, the numbers 1 to 2 in the global low and middle income countries is terrible, but we're not doing that much better. We have a few 3s and a few 3 to 1 to 1 that are not very good. That shows that it's global to local. So how does that mean, global to local? We grabbed interventions that had evidence. We did the cultural adaptation. We brought them to Mozambique. We did it very well. With COVID, we actually had the ability to do things by phone in Mozambique, as the ministry decided to uptake that for the care. But then I applied for hard to get a supplement, because I was, most supplements in a study, they tend to be done in the site where you're doing the study. You discover something that is not part of the aims, and you ask for a supplement to make sure that you have access to do and take care of it immediately. So I convinced NIMH that context can be COVID and the lack of help and the need for more, and they gave me a supplement to bring what we've done in Mozambique to the US. So we're doing a pilot in New York City, and we're hoping to scale up within New York State. And just out of the presses, we're developing a mental wellness equity center, and I'm going to be the director at Columbia. And the idea is to have training, services, research, and education. It has a nice big vision to be able to address mental and substance use disorders, disparities, and social determinants of health. We have added a financial wellness tool to our section, and for training, supervision, and services, all in digital platforms. We're going to have a mental wellness training institute to create a mental wellness community workforce. And I've mentioned, this is what I have shown you before, that we're organizing to do in the US, but we will also add a financial wellness care into our work. Thank you for your attention.
Thank you so much, Milton. This was a tour de force and really some excellent work. It really was global to local. I know that there are some questions gearing up in the chat. I just maybe would like to start. Well, first I want to say congratulations on the new center. We're looking forward to hearing more about that and seeing what you will be doing. With regard to the stepped care model that you've developed and are implementing, I often like to think about, like, what would a public health approach to mental health look like, in New York City, in the US, or globally. I'm sure you've thought about this too. Is this stepped care model part? It seems like it's important to scaling care. And maybe even it helps with prevention, but there has to be some stuff outside the healthcare system too. And I'm wondering what you see. Is this model something that moves us closer to a public health approach? What do you see as some of the critical components of a public health approach to mental health?
So, the same way I always think, like in implementation science, you need to get your partner and figure out what the partner wants and how to do it with their knowledge of the context. So there are multiple, we are very adaptive on what we created, because anybody can do the screening, anybody can do the treatments. So we like to adapt to what the context once allows is acceptable and feasible. So there are multiple opportunities. One is creating a community mental health workforce with lay personnel that could be either part of a health system or part of the mental health system or part of a community system. If I'm working with one institution, is how they can do it. If I'm working with a health system of several hospitals, there's a method to try to understand, where everybody comes up in an implementation science mode, trying to figure out what would work the best, where everybody feels that it's acceptable and feasible, rigorous. So it's very adaptive about who can do it and how to do it, over the phone. The idea why I was so eager to get the proxy is because we waste so much opportunities in just, evaluating one person at a time. Whereas if I have you coming to see me, for example, I can just once a year ask you questions about your family. And I can then, try to figure out how to talk to them. So there are multiple methods that the community can be a part of that. And for example, you identify me, I live with you, I'm your brother. Identify me as having a problem, but when somebody asks me, I don't have a problem, we already can connect with you to do prevention, even if you're under a diagnosis. So there are subsyndromal symptoms that people may have. So in our tool, remember that we do yes and no, but we actually have a Likert scale. So we can determine, even though you don't have a disorder, there are a couple of issues that are going on, and I will address them. If I would have more, in Mozambique, I couldn't do that because I don't have the funds to do it. But the idea that with those 3 items, I can figure out that you don't have a disorder, but you're having something, I can try to do prevention with you and figure out that could be even, TikTok in your phone, multiple methods of, because you may not want to see anybody, but I can provide you things. So there are many methods to adapt these into.
That's really interesting. Thank you. So I know Sylvie has her hand raised with some questions. Sylvie Cohen. Others, if you have questions, please raise your hand and we'll get to you next. Sylvie, go ahead.
Thank you very much for the presentation. I'm very interested in the topic. No, I'm not a specialist, but I've lived in Harlem for 25 years. I worked for the UN for 30 years, and I work for WHO. And I'm really glad that the title includes global and local. I would like to, now that I'm retired, challenge you a bit to bring the global back to local, and Harlem in particular. What we are struggling with, and it's funny because I studied with Rogers on the diffusion of the theory of, or diffusion of innovation. It's not about an innovative model of care right now. We are struggling with a business model for treatment, okay? We are dealing with specific providers, type of providers, and specific type of treatment limited to delivery methadone, and now probably a safe injection sites. And the problem we have when you look at the community profile on health community profiles in New York City, you don't have a public health approach at all. As you said, we look at one patient at a time, or one overdose at a time, or all these disaster indicators that are not looking at the full picture. So my question is, how do you include really a public health lens, but I would say an environmental lens as well, because what we are looking at now is not the acceptability of your intervention or only the viability, but we're looking at the community cost, the cost to the community. How do you incorporate? It's not just about accepting, it's a win-win situation, okay? Because we are creating now, when we continue ignoring the fact that providing drugs medically attracts a parallel market for drugs, we're not real, right? We're not looking at the boomerang effect and the toxic effect of the treatment itself, or too much treatment, or one specific. Thank you.
Thank you, Sylvie. It's a huge challenge, and I don't know that I can answer the whole part of it. I agree with you that we have a very difficult system, a really poorly organized system, and that we have a lot to do. We do need to create a different workforce to provide care, because we don't have enough of anything, and not only mental health. Drugs are a huge issue, and I agree with you. I'm having several implementation studies about drug use, and so there is a new mentality that needs to be created. So Victoria, I know that has her hand, and she's getting a beautiful grant for transformative care. There's a lot that we can try to do in academia, but we need to infuse our thoughts and ideas to policymakers. And the reason why I'm saying this is that COVID is an opportunity to do that. Before COVID, nobody was talking about mental health, but when COVID came in, you had providers getting depressed and suiciding, et cetera, et cetera. So the system understood how difficult and how real was mental health, that it was bad before and the burden is worse now. So people like us have an opportunity that we need to take and grab and do something about it. Yeah. I think that we need to create a workforce between us. So I'm looking at Victoria. We need to figure out how to work together to do things. I know that the city is doing things, but
may I just suggest about working together, and I will be very brief. I would like to enlist all the academia working in public health and other social programming, social policies at Columbia, at CUNY, at City College, whatever you want, New York City, and School of Science, to really collaborate with us. It cannot be like you have a quiet campus.
No, Sylvie, let me explain. I actually...
I'm just suggesting. This is positive.
No. I want to answer to you. I'm not thinking that you're negative. Implementation science is not a science of one specialty. It's a completely interdisciplinary, transdisciplinary. I don't pretend to know it all. Actually, as an implementation science, I always say that I know nothing, and I put people on the table, try to get the most from them and work with them to create a consensus to change things. Because if I just come in saying I know how to do it, 3 people are going to listen to me. So I agree with you. We're in a process, and that's why I've said Victoria 3 or 4 times already, because I want to stimulate the process. Thank you so much. Next.
All right, Vicky, no, you're up.
Yeah, well, first, thank you so much for your talk. It was really, really great. I loved how you really drew the connection between mental health, all the global work and implementation science, and brought it back locally. And the app, I think, is really amazing in terms of, pulling together 99 items and condensing it to 12 items. I think that's the biggest challenge in terms of addressing the needs of the community, because we just can't give that many measures. And, so I think that's really wonderful. I'd love to explore ways of actually using that in our project.
Of course, yes.
That would be great. But also, I think wanted to address some of what Sylvia just mentioned in terms of collaboration. And, I think there's a lot of redundancies in the system, and then there's a lot of gaps. There's so many people doing individual things, and all of this is just such hard work to do, and it's so draining. And we need to figure out ways where we're not duplicating or leveraging each other's work, and we're extending it. And there's so much room for that because the field is so young, and especially in terms of task sharing in the US, because we just don't know the right strategies to use to sustain it. We know how to develop folks, but to actually make that feasible so that it can be implemented by community organizations or by other types of organizations and within their financial incentive plans, because that's where the disconnect is also. I think in CBOs, they're providing a lot of the support services, but they're not the ones making the money off of it. Healthcare is, they address the social determinants, they're breaking their backs. They're the ones that have to cut staff because they're in the community, they're working for the community, but they're not getting the breaks. And so figuring that out is one of the things that we hope to do in Harlem Strong Collaborative. But also, I think there needs to be better collaboration across researchers, because there's so many that have, developed things, and instead we're all like developing new things all the time, and so we're not even using the things that have already been developed.
So I 100% agree with you. I began as an HIV psychiatrist who was not trained in research, and I only became a researcher because I knew that I was doing one-on-one and I was trying to change a clinic, and it was such a headache to try to figure out how to change a beautiful clinic with lots of resources. We had 12 mental health providers, and nobody wanted to change because, I was not the director of mental health, but, even when I improved the access to mental health, I realized that it was a huge problem. So my narcissism is not that big, so I'm happy to share, I'm happy to join, and we're being recorded. So Vicky, you're stuck.
The other question I have is, we're also doing social determinants as well, and economic stress, and was wondering about your training program and what you guys will be doing around the economic stress part. You said part of it would be financial incentives, or if addressing the financial stressors. Nope. Okay.
We're not going to give incentives. So that's not yet what we're doing. We wanted to start first by working with the community to educating them in how to get better taxes, how to get credits, how to get what's available, and then begin the process of figuring out what to do for incentives. We felt that we needed to do one step at a time. So we're going to be working with Kelly Kelleher, who's a wonderful guy, who is helping us create this portion of financial. But I am eager to figure out, just like I'm about to do that in Mozambique, that I'm going to be working with social determinants and incentives. And in Brazil, with Cristiano Eduardo, a collaborator, there's something called Bolsa Familia that they do in Brazil, that the idea of trying to bring it here. So because I'm not yet an expert in that area, I'm putting it in as a beginning stage, but I'm absolutely eager to figure out how do we address it even more.
Yeah, that's great. That's really great.
But we need to talk.
Yes, absolutely. Thank you.
Milton, I had another question, and I also see one in the chat. My question is, so I think you must have very good data on implementation outcomes, given that you're using an app. And I was wondering also, are you measuring mental health outcomes? If so, how will you know about the impact of the treatments that are following up on these positive screens?
So great question. And so first, as we are training and getting into the study, I'm looking now, actually, this month, we're going to look at the use of these 12 questions longitudinally to see if it allows us to detect symptoms, and together with other measures, and see if we can try to build something that is shorter, so we don't have to ask about everything. And because people have one or two disorders, and we have a method of following symptoms across time. So we're going to be doing that. And not only, this is not a study that we measure every 3 months or every 6 months. This is a study that it's based on the system of care. So when the patient is in, is when we get all the data. So it's going to be it's a study that works as a system, not as a study. So if Milton needs to be seen weekly, we know about Milton weekly. If Milton needs to be seen weekly for a month, but then not for another year. So we're going to have a variability of data and for multiple disorders, but we are getting that data, and I'm going to probably call you to help me figure out how to handle it.
That's great. Yeah, I mean, the first question is, like, if someone screens positive for anxiety, are they getting the anxiety treatment that you have outlined as part of your protocol? And then after that, are they seeing reductions or improvements in anxiety symptoms? I think it's,
so
very
you're absolutely right. So part of the issue is there's two fidelities, one fidelity to the intervention and then fidelity to the pathway of care. So if you are the community health worker and you find that I have depression, the tablet takes you to do immediately the intervention. If you choose not to do it, I know. And if you decide that you're going to ask the primary care provider to do it, but being implementation, I'm going to try to find out what's the reason, what is the impediment for the community health worker to do the work. So the same tool, which we use every time, allows me to know when are you getting seen, who's seeing you, and therefore I can test the pathway and the best, the most adaptive care to the system, because who am I to decide who has to do everything? So the system will decide, and we're going to work with them in trying to figure out what's the best answer.
Thanks. Dino Mohandas has a question for you.
Yeah, I was very interested in what you were doing behind the scenes on the sociocultural impact on stigma, especially wanted your insights on, there are three categories. There's anxiety, depression, there's substance use, and then there's major psychiatric illness like schizophrenia. Do you feel like in Mozambique, which you are seemingly most familiar, whether the stigma orientation towards these three categories is different, and whether that impacts on the efficacy of your program, and whether you're collaborating with other community agencies, perhaps, to move the needle on stigma?
I love that you're not only asking.
Very interesting presentation.
Thank you so much. I love that you're only asking a question, but you're promoting more. So the answer is, we're working in a rural area that has never received mental health care before. Maybe a few people that have very severe disorders who the family either takes them to a hospital or brings them every so often for medication to the city. And remember, they may be an hour away from the rural clinic, but they could be 12 to 18 hours away from the clinic where psychiatric medications are there. So in many ways, this is a totally naive group of people that disorders are not necessarily ever been diagnosed. So we're learning as we're moving forward, even with the providers. So I have to tell you that the psychiatric technicians that are very well trained, they were talking about psychiatric illness as a weakness, which is stigma. It's stigmatizing your own patients. And we realized that we first needed to do, and by the way, I work with the ministry, so this is not that I'm going to do it. I, identify problems and we figure out how to do them. So as we're moving forward, we're going to understand those differences. The other element that I didn't mention is that in countries like Mozambique, psychiatrists also take care of epilepsy. So actually half of the care that takes place in psychiatry is epilepsy. And because epilepsy can be easily treated for some people, not for everybody, and you have results that are immediate, the stigma of neuropsychiatric disorders has been reduced by first expanding epilepsy care, which they did before us, and we are integrating into the work that we're doing. So I didn't even put the epilepsy work. We have a measure for epilepsy and a route for epilepsy. So what you're saying is absolutely correct. And if you have an idea who wants to work with us in trying to do that better, I'm happy to collaborate, because I know that I cannot do it all. And this is a one grant just doing all disorders. That's the only thing that we're doing.
Are there any community organizations that would be interested in destigmatizing mental health, or is that outside of the range of their socio-political interests?
You mean in Mozambique? Actually the ministry is the one that leads that. So I work with the ministry we're doing awareness campaigns. We're doing that work, and we're about to expand that now. One of the issues that I didn't mention, severe mental illness, medication alone is not a good treatment. So our next step is community care for severe disorders, because just giving people a medication is not ideal. So we're going to be applying for a grant. I'm a researcher, I have to do it through grants, unless people want to give me money, that I'm happy to accept it. So we're about to apply for a grant in creating community mental health care. And that would also help us understand much more the question of stigma, because the more severe the disorder, the worse is the stigma. Definitely. Great questions.
Or not, there are many cultures in Africa that actually view people with severe psychiatric disorder with a certain acceptance that's not seen in Western cultures. So I don't agree that the most severe psychiatric disorders are most stigmatized.
Maybe you're right. We will learn with that. What we have seen is that people with psychosis are treated sometimes by traditional healers, which do not treat them with psychiatric treatment. So it can be very complicated. So I think that there's a variability sometimes when the severe disorder is very positive symptoms of schizophrenia, people end up being put in a room, or so I think even within the disorders, depending of how active the person is, there's multiple differences in how, and sometimes they're put in a room. In Mozambique, we haven't seen the chained to a tree, but many times their relatives drive 12 hours to a hospital, and they drop the person at the door because they don't want anybody to tell them we don't have room for you. Is that stigma? I don't know. They're burnt out perhaps from taking care of somebody who doesn't produce, and eats the food, et cetera, et cetera. So we're going to learn a lot. I agree with you. And I'm sorry that I made maybe I'm making a wrong comment, and I'll learn about what's happening there with that.
Couple of last questions in the chat, Milton. One, Teresa Flourmond asks, does the step care model address maternal depression? And then Ilana Pinsky asking, Thank you for the presentation. Okay, so someone who's part of your project in Mozambique, wondering what's being done to make sure this beautiful task shifting program is actually becoming sustainable.
So yes to perinatal and mothers, because they're part of, in every clinic, perinatal is one of the most important elements, and community health workers are very aware of pregnancy and what they need to do, and all the elements to take care prior to. So yes, we're going to be doing so most of the care that it's done globally about perinatal is perinatal depression. And we know that it's not the only care that is needed. That's what I'm talking about, one at a time. We would be able to know if a pregnant woman is depressed or is actually psychotic, because they may appear psychotic, and then we can figure out what we can do. So we will. And Ilana, I'm glad that you're here. The sustainability is as follows. The technology is there. We have trained up until now 50 local trainers. We have trained all the psychiatric technicians that are co-training and supervising, and we are trying to expand the system. My only way of doing it is through research, but I would always allow somebody to give us money to expand it in another way. And the ministry is very committed to doing this. So I use research to practice, research to expand, because it's the only way. I'm not rich enough to put my own money into this.
And a last question from Sylvie Cohen about does the project address domestic violence? I think you did say there's an interpersonal violence screener in there, but
yeah, it's a great question.
So
it's a great question. What we are, again, this is one study that has 5 countries in capacity building, in a population of 9 million, training 600 providers, and we're doing all disorders. So I promise you that I cannot take care of everything. So what are we doing? Because I have a T32 that can apply for case. So one of my care awardees is doing intimate partner violence and couples care within the study. So the way that Mozambique and us have decided is that if we can, this is going to be a laboratory of implementation science in mental health, that we started with this, and then we will be adding as we go along. So it's almost like an idea site for mental health, where we continue adding as needed or to learn more. Obviously, my fellows have an amazing opportunity, but if other people want to be involved, I will always say yes. You just have to be nice, not too narcissistic, and kind. Otherwise, and be able to listen. Then you're more than welcome to work with us.
Okay, and I guess maybe the last question can go to Professor No.
I was just thinking about, all that you're doing and this, combining multiple disorders together, which is so important and so needed. But one of the challenges with that, especially with task sharing, is the overload on providers and task sharers, because one of the reasons why I think we start with simple and start with single disorders is because task sharing needs to be simplified in order for interventions to actually be delivered effectively and then be adopted. So when you combine all of these different tools and tasks, how does that then impact the system? And does it make it, how long does that take? And, what is that process for making that successful? Because for me, that's a huge challenge.
This, I love challenges, number one. Number two, our study is to figure out who can do what. So that's where we have 3 arms to see how it gets combined. And we're about to add even more community care. I don't know that I have the answer, but I think that the community and the collaboration has to find the answer, because, just because we know math to teach in schools, we're not going to teach science. We have to take care of everything. We cannot just say, and I'm going to disagree with you a little bit. I don't think that it's just about the difficulty. It's because mental health research starts with one disorder. We screen, all the evidence-based treatments are about one disorder at a time. There are a few that, CETA and ours that are a little bit more, and ours is everything. So the system of research has not talked about all disorders. And one of the elements that I'm very upset with people, I don't like the way we publish. We say the mental health of mothers, perinatal mental health, when we're just doing depression care. It's like, we are not presenting a reality in a lot of the journals and in the way that we communicate what we do. And therefore, the funders don't realize that we're only doing one disorder at a time. So we create an image of what we're doing that actually works against us. Because why would you do more if you're already doing perinatal mental health when you're not? When you're doing so, there's something about our language that can interfere the process of us having, and even people, when you go and say, I'm going to do mental health and I only do depression, it's like, but that's not good enough for us. I need more than that. In one of the first global mental health conferences in Washington, because I speak Portuguese, and the Ministry of Health from Brazil was one of the guests, and nobody thought that he didn't speak English. So I sat for 3 days right next to him. And he taught me so much by comments that he was making. He was saying, what do I do with a depression intervention that I have 3 months and 6 months effect? I cannot I cannot do this, I cannot just treat depression. So he was the one who trained me that I needed to think in a more, all-encompassing, which it's very challenging, but we're doing it. So, I don't know.
Yeah, would love to talk to you more about that and hear about, how you guys are doing it.
Yeah, we need to change New York City.
Yeah.
Milton, thank you so much for sharing all of this with us. Thank you also for being such a constant friend to us at the CUNY School of Public Health and at our institute. I think your work, your vision, it's an incredible vision and a really important one. But I think what also you've shown us is that you're working to make that vision a reality on the ground and in the real world, with the potential for paradigm shifting implementation. And I really look forward to seeing what else comes out of your research agenda in the coming months and years.
what we can do together.
And what we can do together.
Thank you so much. You're a wonderful crowd to talk to, and thank you for listening, and let's figure out how we can change things. Thank you so much.
Thank you, Milton.
Take
Have a
care.
good night.
Bye-bye. You too.